proteins that govern how a cell works. We'll see them in diabetes, so they do real basic things that are widespread. So you see these PPAR alphas in all types of tissue. They predominate and concentrate in the liver. There are other PPAR delta and gammas which are in other cells of the body. So by targeting them, we can then alter the way the cell does or regulates things like fatty acid oxidation, glucose transport, glucose metabolism. For these, they have a lot of regulation over lipid metabolism, in particular fatty acid oxidation. So I want to just walk through fatty acid oxidation so that you kind of have just a review. So you remember triglycerides can come in the body in 3 different ways. You can eat them through fats. Your liver can synthesize them, right? And we then store them away in fat for long-term storage. The one thing that's different with fats than any other fuel that the body takes in is that we have unlimited capacity to store it, right? So that's one of the things with obesity is we have unregulated storage of fats. So these fats, wherever they come from, can be then changed into free fatty acids and glycerol, right? So triglycerides, that glycerol background, 3 fatty acids attached, right? Okay. So it's a major fuel source for the body. So the liver is one of the places where that oxidation can take place. So with that fatty acid oxidation, it has multiple steps, and some of those steps we can impact with this drug. So just as a reminder, those free fatty acids come into the liver activates them, they move into the hepatocytes, the liver activates them and then moves them into the mitochondria. Okay. And in the mitochondria is where beta oxidation takes place. And the result is we produce energy. We also produce electron transport proteins like NAD and FAD. So did I put it on here? The net generation of these is 120 molecules of ATP. Anybody know how much glucose will produce? The same amount? 32. So you see the big difference. That's why fat is considered such a storage of energy, is the big difference. So we can get 120 molecules of ATP out of it versus 32 out of a molecule of glucose. Okay. So fibrates affect that beta oxidation, which is what's taking place in the mitochondria. And one of the things it does is it increases the first enzyme, which is the first step in beta oxidation of fatty acids, and that's that acyl-CoA synthase. So if we can shunt more fatty acids into this beta oxidation, then there's less available for the liver to make triglycerides. Okay. So that's one of the ways that we can decrease fats in general with these agents is we oxidize them to a greater extent. So if those triglycerides aren't available, then what happens to VLDL synthesis? It goes down. What happens to the production of LDL? It should go down. Okay. Fibrates also decrease the synthesis of one of those apoproteins, apoprotein C3. Go back in your handout and look at that chart I gave you and tell me what C3 does. It decreases clearance of, say it again.
It inhibits clearance of triglyceride-rich lipoproteins.
So it inhibits clearance. So what it does is it impacts lipoprotein lipase. Now C2 is a cofactor which enhances LPL but C3 inhibits it. So the fibrates inhibit that. They inhibit C3. So they allow lipoprotein lipase to act more, to have greater activity. So what does that mean? What does that lipoprotein lipase do?
Breaks up chylomicrons?
Say what?
I don't know if this is right, but does it break up chylomicrons in the small?
Right, so it continually strips off triglycerides and fatty acids from chylomicron remnants, also IDL, converting it to LDL. So fibrates increase that metabolism, so further lowering the amount of triglycerides available and those particles that are triglyceride rich. Let's see. The other thing it does, look back at that chart again, is it increases ApoA1, ApoA2, and ABCA1, which we haven't talked much about. So what do ApoA1 and A2 do?
Activate enzyme activator adipase.
What's it do in terms of structure? Where is it mostly located?
HDL.
HDL. Okay, so that's really important as you are also taking down those triglycerides, you're enhancing your HDL. So why would that be good? Part of that reverse transport system, so it enhances the efflux of cholesterol out of macrophages that are in your blood vessels that are going to cause foam cells or in the intima itself. Okay. So that ABCA1 is a structural protein that helps that efflux. It helps move cholesterol from inside of a cell, like a macrophage, into the bloodstream where HDL can pick it up and go back to the liver. Okay. So that's what fibrates do. So in that little sentence I have under mechanism of action, activates PPAR alpha, increases lipolysis, eliminates triglyceride-rich molecules, and reduces the synthesis of ApoC3. That's what's behind it. So that unpacks, those 3 slides unpack that sentence and give you the background as a reminder. Okay. So you have this slide, and it's just kind of a summary slide. So here's where you've got those free fatty acids decreasing because you have increased the activity of that enzyme. That's the first step in beta-oxidation of those free fatty acids. So that decreases triglycerides. You also have that decrease in C3, which you're no longer, which decreases the production of VLDLs and allows them to be metabolized by LPL, and you've got those increases in those ApoA1 and 2, which are going to structurally be part of HDL. So, in summary, you get an increase in HDLs, decrease in VLDLs, and a decrease in LDL, for the most part. Okay. This next slide is a really good summary slide. Came out in New England Journal about the time that the fibrates, or Jim Fiberzil came out. Has a really good summary explanation under that slide in your notes. So I would advise going back and reading through that. This is a much simplified from some of the other ones I've given you. So it's more of a summary slide. Okay. So let's look at the lipid profile. This drug is best on triglycerides, doesn't that make sense? So it's one of the most powerful drugs, along with niacin. These 2 drugs can decrease the production of triglycerides to the greatest extent. So 20 to 50% reduction in triglycerides. So on LDL, you get about, what's it say, 5 to 20%? Okay. And HDL will go modestly. It doesn't go up as high as niacin, but in about the 10 to 35% range. Now, the paradox with this is that for people who have really high triglycerides, when you knock those triglycerides down, you may see their LDL go up. In fact, about a third of people have a rise in LDL. So that's kind of concerning. We're giving them a drug to decrease their triglycerides. Usually we're going to use these in people whose triglycerides are over 500 and are at higher risk for pancreatitis. So our goal with gemfibrozil is usually not LDL reduction, it's triglyceride reduction. And about a third of those people's LDL will go up. It appears that most of the time their LDL are the more buoyant, bigger LDL. So why would that be a good thing as opposed to those dense LDLs that we talked about yesterday? What's the problem with the dense LDLs? They get into that intima easier, so they're considered a more atherogenic as opposed to the larger. Remember that one slide I gave you with all the different colors of the lipoproteins that went up the scale? They are bigger, they're not as atherogenic. Doesn't mean they're not atherogenic, but to their predisposition to it is less than the dense ones. So you have to watch. You have to watch those folks. Sometimes that's when you sometimes go and will treat them with a statin. I told you never to do that. Sometimes you will use them in conjunction, but you really have to watch them. Their risk of myopathy starts at about 5% and goes up. So those folks are more at risk. So contraindications, pre-existing gallbladder disease. If people are already making gallstones, then when you rapidly reduce their LDL, they will precipitate out cholesterol in their gallbladder, and they will more likely get gallstones, particularly in the first year, 6 to 12 months of treatment. I've seen that happen. Hepatic dysfunction, any of these drugs that work on the liver are going to have the potential to cause liver disease or more of a drug-induced hepatitis. So following your serum transaminases will be important with them. We don't use them in severe renal impairment. Gemfibrozil in particular is cleared that way, and so it can increase the risk of side effects. So precautions would be, if you're really worried about gallstones, this drug will put them at great risk. Using them together with statins increases that risk of muscle damage and myopathies. Drug interactions, we just talked about that. Acetamib is recommended you not use it, but this is a cholesterol blocker we're going to talk about in just a few minutes. So not using it because it increases the risk of gallstones. Let's see, adverse reactions, I've hit all those. Monitoring. So this drug is different. It takes this group of drugs about 3 months to see full effect of cholesterol on a lipid profile. So the other ones I told you how long. I use a statin. When do we usually start monitoring? About 4 to 6 weeks. This one, it's 3 months. Now you'll see changes all along, but to assess how the drug is managing them, it's going to be about 3 months. Their doses are more fixed. There isn't much dose escalation with any of these, the fibrates. So a lot of it's going to be based on diet as well. These folks will do a whole lot better if you will also have them see a dietitian, particularly those that have really high triglycerides. Most of the time their high triglycerides are going to come from high sugar, high fat. If they've got poorly controlled diabetes, you will never control their triglycerides unless you control the diabetes. And the other is thyroid disease. Thyroid disease also can alter their lipid. It tends to have more effect on LDL than it does on triglycerides. Okay, so real-world application. There's no data saying that these decrease vascular events like we have with the statins. but they're very powerful in terms of their triglycerides. So that's where you're going to look for those. You're going to watch for LDL to go up after initiation, particularly the higher the starting triglyceride, the more likely they are to have elevated LDL. Let's see, so primarily when triglycerides get about 500, you should have a, I don't know why I put a high threshold. I think I was thinking you should have a high threshold when thinking to use them, but if you have a low threshold, once their triglycerides get over 500, you have a escalating risk of pancreatitis. Most people don't get pancreatitis until you get over 1 to 2,000 milligram per deciliter of triglycerides, but the risk starts to escalate over 500. Okay, questions about the fibric acids? Ezetimibe or Zetia is a drug that impairs the ability of the gut to absorb cholesterol. What it does is, this is looking at an enterocyte. So it's looking at a cell lining the intestines. And the cholesterol, when cholesterol levels are very high, cholesterol is readily absorbed. And what it does is it interacts with this NPC1L1 receptor. And it acts kind of like a host, a storage protein. So this protein interacts with the cholesterol. The cell has these chloripin and APC2 molecules in it. We talked about these in the first module. They are very common when a cell is going to endocytose something. So anytime a cell takes something in, chloripin is usually involved. It's usually part of the receptor and part of a storage or a movement of a molecule within the cytosol. So what happens, you have this complex, the cell moves them to kind of this retaining site. And they have a name for it, this ERC, endocytic recycling compartment. So the cell just puts it away, and as long as cholesterol levels in the lumen don't change a lot, it just sits there. If it's high and it influxes, it'll store it away. But if cholesterol levels ever drop, then what happens is the cell will send them back up and will recycle them into the gut. Okay. So what we do when we use that ezetimibe is we just interfere with that ability of that molecule to do its job. So it can no longer form that complex. So when they talk about blocking absorption, that's what they mean. They block the ability of that complex to form, and so the cell can't move the cholesterol in, and storage goes down. So in terms of how the drug works, you've got your little box there in the middle or table. LDL affects about 20%, so fairly good. Modest compared to the others, but not bad. Triglyceride HDL effects are negligible. Contraindications would be active liver disease, renal, hepatic insufficiency, but it's really very well tolerated for the most part. So when do you use it? Usually it's added on to if a statin cannot, if the patient can't tolerate the maximum effects. Let's say you want them on a high intensity dose. So for atorvastatin, what would that be? Let's say we put them on atorvastatin, high intensity, what would that be?
40 to 80.
40 to 80. Let's say they really complain, they can't tolerate it. So we move them down to more a modest dose. Then we can add this on. So usually it's an add-on to a statin. If you had somebody who could not tolerate any of the other drugs, then you could use it by itself. But it's really not intended for that. It was more intended as an add-on. And you can see that it had a, Kristen, is Vytorin still around? I didn't.
Yeah, they
Look
both
it
are,
up.
but they're both generic.
So that they originally came out with a combination product with this and simvastatin called Vytorin.
Yeah, they both went generic last year.
So did the price drop much?
I want to say yes, but a lot of people, like, you know how old the people are, so when they go generic, they're like, no, I want the branding, so we still stock the brand name.
You still stock the Vytorin?
Yeah,
Okay.
and Zediac.
Okay, so again, like other non-statin agents, it doesn't have the data behind it like the statins do in terms of decreasing risk, cardiovascular risk. Let's see. Pretty much it doesn't have a lot of drug interactions, not a lot of side effects, so it's a good add-on to consider. Okay, questions about it? I pulled the slide, it's very, very busy. If you can kind of break it down, it shows all the things we have talked about. And it had a really good legend with it, so it's there if you want. What they're doing is they're taking this is the intestinal lumen, this is the bile duct. They've got a enterocyte here, they have muscles there, they have a hepatocyte there. They have a white blood cell up there, a macrophage that's in the artery that is, and a lot of the first places that the body will try to extract cholesterol from are the macrophages that are in the arterial walls. This is a big interest right now in terms of drugs to the next step of the next set of drugs that's going to come out. It's going to be targeted to cholesterol and atherosclerotic disease is in that area. It'll probably happen in your lifetime that we'll be able to actually get or prevent foam cells from forming because we can get the cholesterol out of the macrophages before they can set up a fatty streak and then cause an atheroma. It has all the chylomicron, the VLDL, the remnants, and the HDL or the LDL going back to the liver. Also shows you the growth of the HDL. It has the ABCA1 that I just mentioned. Anyway, it's a rich little picture. Use it if you want. Don't look at it if you don't want to. But it's got a lot of, they did a nice job in putting everything kind of in one spot. Okay, bile acids. So the liver makes a lot of bile, and it's very rich in cholesterol. And it circulates it throughout the body, recycles it every day. What's it say, 10 times? Okay. We lose a little bit in the feces, but for the most part we just keep recycling it. So the bile acids were developed probably 50 years ago. They were one of the earliest drugs to come out, showed in the Mr. Fit trials, which were in the 70s and 80s. Showed very good cholesterol reduction in people, and it works on the concept of it binds up those bile acids, interrupts that recycling process. So what does the liver do? It pulls more cholesterol in to make more bile acids. So that's how these drugs work. Is they just sequester bile acids, you poop them out, the liver will work to make more. Or it'll extract more cholesterol from the blood and put it into making bile acids. So that's how these drugs work. 3 of them that are still around are cholestyramine, colesevelam, and cholesterol. They all work the same. The one in the middle, Welcol, also has gone after an indication for diabetes. So it kind of has a dual purpose. It will lower cholesterol, also lowers blood sugar. We'll talk about that with type 2. So again, interrupting that recycling system that the body has made up. So if you look on the next page, lipid effects. LDL reduction about 15 to 30%, modest at best. HDL rises slightly. Triglycerides, the higher the person's triglycerides at baseline, the more likely they are to go up. So it's one of the problems with this drug. People's who LDL or triglycerides are in the 300 to 400s, their triglycerides will tend to rise. So contraindications, you can mention bowel obstruction is one of them. These drugs, they form very big, or can, concretions of that bile acid. So if a person doesn't have very good peristalsis, or they have an accretion that's too big, you can get a bowel obstruction from this. Malabsorption disorders over time is if you're using large doses. Their other downside is that they will bind everything. So they'll bind drugs. So it always became a problem in terms of separating their use from other drugs the person was using. When I was at the VA, we used a lot of bile acids. They're very effective, but they take a lot of patient education because you have to teach patients how to mix it, how to make it palatable, and also you have to start low and titrate up. The gut will adjust to them well, but it takes time. Yes.
Well pills, I know you have to take 6 pills a day, and the packets are really expensive.
They do require usually 2 to 3 times a day. You break it up because you don't want to take them all at one time. They are good add-ons. Again, if you've got people who cannot tolerate the statin, these are very good add-ons. You do have to watch, particularly when they're taking like levothyroxine or warfarin, that you avoid drug interactions with them. So that's what I'm saying. I'm making a point. It takes a lot of patient education to accomplish or to get them to be effective in the patient to use them. Adverse reactions, most of the time it's GI, so it's constipation usually, or gas would be the common problems. But at low dose add-ons, they're good in combination with a statin. Questions about those? Okay. All right, let's look at some alternatives. All right, so we've got the omega-3 fatty acids, so fish oils. And they can be used because they tend to be good at lowering triglycerides. So they may be add-ons when you have someone who has high triglycerides and you're not able to get them down through dietary means, using a fibrate. You may need another drug to look at. And so the omega-3s are good in this area. So remember, there's the omega-3 fatty acids are made up of EPA and DHA. These are essential fatty acids, which means what? The body can't make them, so we have to take them in. They're also called marine omega-3s because they come mostly from fish. The fish that are highest in the concentrations are listed there, usually the cold water fish. So anchovies, halibut, herring, kippers, mackerel, mullet. Have anybody ever had mullet?
No. My friend doesn't go mullet. That's where you throw a fish.
Really? It just doesn't sound good.
Doesn't
I mean,
look
if
good
they really
either.
wanted to sell them, I would change the name.
Party with them.
Salmon, sardines, sturgeons, trout, tuna. So 3.5 ounces of fish is about 1 gram of omega-3. Well, what about the other ones? Because there's other omega-9 and omega-6, your patients may get confused about them. Or may use them in combination and not know which one is effective, which one they're going to get good effect if they're using it for lipid lowering reasons. So omega-6 is your linoleic acid, polyunsaturated fats, again another essential fatty acid. You've got your vegetable omega-3s, which are alpha-linoleic acid. And you have your omega-6, which are oleic acid. That's what's in olive oil. So the one we want that for our purposes in here is going to be the omega-3s. The one side effect, you've ever taken them, you get that fish taste. Use the enteric coated, they're really good. Most people don't get that fish herb with them. The other is to put them in the refrigerator. That tends to decrease that reflux fishy taste as well. The other is that the higher the dose you use of these, and most of the time you're going to be looking in the 1 to 2 gram, but if you use above that, you can see antiplatelet effects. So patients may complain of, like, when I brush my teeth, my gums bleed. It's an antiplatelet effect. I'm very careful if I've got patients who are on warfarin or another anticoagulant in using high-dose omega-3, because they can have more bleeding. So they can reduce triglycerides up to 20 to 50%, about in the range that the fibrates can. So they're a good combination with them. LDL, 40% in some studies, almost. So they can lower, in one meta-analysis, they showed that it lowered overall mortality by 23%, cardiovascular by 32%. So they can be quite powerful. If the patient can take and eat fish, there's no reason to supplement them. May be no reason to supplement them. But if they have higher triglycerides that are not responding, 2 to 4 grams range is recommended. For very high triglycerides, there is a product called Lovesa. It's very expensive. And it's used in the dose of 4 grams a day. If you look on the next page, high amounts of EPA and DHA. You can probably buy fish oil, a big container, in the $10 to $20 range. These are $165. But again, they're for people that could take very high doses. So keep it in mind for your high triglyceride patients. Just to address some others, krill oil is out there, it's popular. There is no advantage to it. It's a lot more expensive. There is no reason to recommend it. If patients take it, want to spend the money on it, that's fine, but it has no evidence behind it to use it over the other sources of omega-3s.
Isn't that Becca Red?
It is. A lot more expensive. There just really isn't any reason to recommend it. Flaxseed oil is omega-3s and omega-6s, does not contain a significant source of DHA or EPA, won't lower triglycerides. If the patient wants to take it for other health reasons, that's one issue, but it will not lower the triglycerides. At very high doses, it has LDL lowering effect, but you see there that the amount that it takes, you're running into significant calories. About 200 calories for that amount. So the American Heart Association recommends that it be part of a diet, a heart-healthy diet, and the recommended there is 1.5 to 3 grams of alpha-linoleic acid a day. So it's not a substitute for fish oil. So that's one of the things I want you to take away if your patients are on it and they think that that's going to provide them some heart health. Yes, it can, but it's not going to treat LDL or triglycerides in that range. Some other herbal products that have been touted for their cholesterol lowering. Garlic is one. It's been around a long time. People tout it for its heart health. It really doesn't have a lot of effect on LDL. If patients want to take it, it's not going to hurt them. In high doses, you can see antiplatelet effects as well. They can also smell like a pizza factory walking in. There are deodorized garlic that you can get. That's what I advise them to do if they're going to use it. Or just add it to your foods and enjoy it that way as well. Red yeast rice. You heard this one? Mm-hmm. Okay, so what do you know? Kathleen says yes.
There are people that were on it.
Okay. So red yeast rice, so a lot of our drugs come from natural products. The statins do. They come from molds that are in the dirt. Red yeast rice is a mold on rice. It is a statin. It is very similar to lovastatin. If people want to avoid a statin and they want to take something natural, I'm sorry, it's still a statin. It works the very same way. The problem is that it is a supplement. So what do you remember about supplements? They're not regulated, they are not controlled. So the FDA has come out and called them illegal. The reason they do that is anytime someone tries to take a supplement and add in, they've done this with like Viagra, they've added it to products for men and touted that it will increase their sexual strength and all, what they've done is they've taken Viagra and they've added it to that. So whenever a company does that, the FDA usually will move against them in terms of this kind of action, illegal. Doesn't mean the drug there's anything wrong with it, but it means that you are now touting a drug that the FDA controls. You have now taken it into the supplement realm and you are promoting it for health. And that's against their rules. So that's why it carries, if you ever look it up, it'll carry, the FDA will classify it as an illegal drug. The other is that they got into trouble with red yeast rice years ago in terms of the additives and the other things in it caused people health concerns or health issues. So that's the deal with red yeast rice. Contaminants aren't controlled, so if people want to treat their cholesterol, tell them a statin would be just the same and it's a regulated drug. Some others that are on this page, the polycosanol is a drug that is touted to also act like a statin. There's no evidence for it, really isn't a reason for people to use it. Soy proteins do have an FDA labeling with it. If you look down, they have labeled it as part of a health or a heart healthy diet. To be eligible for that FDA labeling, it has to contain 6.25 grams of soy protein per serving. And some examples of that kind of content are listed there for you. Effective amount a day is about 25 grams. Lowers LDL in the 7 to 10% range, so not bad. Not a bad add-on to, for people that are very mild or moderate, or if they're adding it to what they're already doing, would be reasonable. Phytosterols. Okay. So phytosterols can compete with cholesterol for absorption. And so that may be one of the ways that they help lower cholesterol. They've been touted to do that by as much as 6 to 20% when used in a 2 to 3 gram per day range. But high levels have also been noted to have adverse effects, to be atherosclerotic or to promote heart disease. So low doses are probably safe, high doses are probably have some deleterious effects on the heart. So avoid them in patients who have very serious cardiovascular risk or cardiovascular disease. Do you want to add anything with that? Okay. Fibers. So fiber helps reduce cholesterol. We know Metamucil in about 7% range. Oats are in about the same range. What did they say? 5 to 10% for blonde psyllium husk. I brought a picture of them. Wasn't sure what they look like, but they live up to their name. So anytime one of my theories is if you are replacing these foods, you're replacing higher fat foods that raise cholesterol, have higher saturated fats, with these type of products, your LDL is going to go down. So we know when people eat whole grains like Cheerios, oatmeal, that their cholesterol levels go down. Too much of them can interfere with other good nutrients, so be careful in patients overdoing it. But these are reasonable add-ons. They're part of a heart healthy diet, but they also can be used by people who are on agents to also reduce their cholesterol. So in summary, on the top of page 24, the ones that are effective and likely safe are fish oil. Likely effective and likely safe would be niacin in low doses. Remember, in high doses, it does have several toxicities. Fibers, phytosterols. Possibly effective, possibly safe. Flaxseed, gum gar gum, soy, artichoke extract, pectin. A lot of those I didn't go into detail with, but they are touted. That's one of their health claims. Insufficient evidence and probably safe would be alpha-linoleic acid and inositol nicotinamide. Do not recommend garlic, chitosan, soy isoflavone supplements, and avoid red yeast. So if your patients are using those, if they're using garlic, I wouldn't discourage them. I just would, it's from the standpoint of you recommending them as cholesterol-lowering agents. I think the next 2 pages I covered in nutrition. It's looking at what's saturated fats, what are the good monounsaturated fats. If you look over on the last 4 pages, what I want to return to now is the guidelines for cholesterol lowering. Remember I told you there's 2 different guidelines, the National Lipid Association, which is really comes out of the more traditional NCP guidelines, the National Cholesterol Education Program, and then we have the American Heart Association and the American College of Cardiology that put out their guidelines in 2013. They have different approaches. I would say whichever one you choose is not wrong. They're a little bit different though. So let's look at the chart on page 26. So if you look at the National Lipid Association, they have targets. So what they have done, they still risk stratify based on cardiovascular risk factors. Right? So they are the ones that had 0 to 1 low risk, 2 or more hot and moderate risk, diabetes, atherosclerotic disease, highest risk. They also have targets. So they have LDL lowering less than 100 for those who have atherosclerotic disease less than 70. If you look at the American College of Cardiology, they don't use any LDL targets. So I told you for long-term practitioners that kind of didn't undo them, but it's like, okay, well, how do I know that I've reached a target? We're so ingrained to have markers that tell us when we reach an outcome. The other is for patients, because they got used to, my cholesterol needs to be this. So it removed those. Goals of therapy, so with the National Lipid Association, their goal is they look at non-HDL cholesterol. And their treatment goal is less than 130 or less than 100. That's their first goal, and then the achievement of an LDL is next. So what's non-HDL cholesterol? It's everything that's not HDL, so it's the total minus the HDL. The goal of therapy for the American Heart Association is use the right intensity statin based on risk. Statin initiation. For those in the American Heart Association, it was based, if you've got heart disease, you need to be on it. If your LDL is 190 or above, you need to be on one. If you have diabetes or a 10-year calculated risk of 7.5 or above, you need to be on a statin. For the National Lipid Association, theirs is based on risk. If it's low to moderate, then you start a drug when your LDL is, or your non-HDL is 30 above goal. And for high and very high, statins can be started at any time. The use of non-statins, the American Heart Association really they didn't include that kind of data in their guidelines. Since they don't have cardiovascular outcome data, they really don't have anything to recommend to you if the statins don't reach their goal or the patient can tolerate them. For the National Lipid Association, they have included those in there. Okay. If you look at the next page, that's that flow sheet we talked about yesterday. This is the American Heart Association. So if you go down there and they start with atherosclerotic disease. And if you have that, then it's either a moderate or a high intensity based on age. And as you go on down, they look, well, you don't have heart disease, you have high LDL. Then which level of statin do you need to be on? Diabetes, again, back to those intensities. That's why I want you to know those, what falls into a high and low, or a high and moderate statin. So that's all they have. Their thinking is that if you lower LDL by 50%, then you have achieved a great risk reduction. And those drugs are fairly consistent with achieving those goals. Not everybody will respond and not everybody will tolerate them. So then what do? Well, they don't really have any guidelines as to what to do from theirs. If you go and look on the next page, this one does a summary for you of those guidelines. So this is the American Heart Association guidelines. The first two I have covered. When it gets down to patients over 75, that's a group that everybody's like, well, what do you do? If you get to 75 and you haven't had heart disease, and you have a high cholesterol, should you go on a drug? Well, there's not a lot of good data to guide you. You have to look at physiologically how accurate, what is their physiologic age versus their chronologic age. So if they're physically in very good shape, look like they could live a long time, then you might want to consider a statin in them or not. Patients 21 and older, if they have an LDL above 190, they recommend putting them on a statin. You've got a very young patient and you're looking at 40 years, 50 years, that's a long time to be on a drug. More than likely the treatment will change over that time. But it's also looking at if you have high risk and you can reduce it early, you can reduce a lot of the development of that disease before it becomes manifest, and then there is less options that you have. So that's their thought. Going back up to the very top of that, why don't they choose targets? They make some good points. Some is that the original cholesterol targets, the original LDL targets of less than 130, less than 100, less than 70 were done by consensus. That means a group of experts got together and said, based on what we know, even though we don't have the interventions to prove it, we think these are the best targets. Okay. So now as more data has come out and more interventions have been done with very specific outcomes, they can more stand behind and say, if you do this, you're likely to achieve a great reduction in cardiovascular events. So that's their argument against using targets. If you go down to the bottom, non-statin agents, the problem comes in with triglycerides. What do we do with them? Early on, they weren't considered to be atherogenic. They weren't considered to be part of the problem that we were dealing with when people had heart attacks. Now people feel differently. This is always the approach or this is always the way things go as we learn more about a disease. It's like peeling onion off. At first you're ignoring the stuff that doesn't seem to matter, but as you get down into it, you start to find things do matter. So what do you do with high triglycerides? Well, in diabetics, they're really important. In other population, may not matter. So usually non-statin therapy is addressing the triglyceride. Probably in your professional lifetime, more and more guidelines will come out and stratify people. If you have this, if you have high triglycerides, you need to do this because that will reduce risk. Right now, there's nothing that says it reduces risk. So non-statins are usually going to be geared towards those triglycerides. The biggest thing we want to prevent at this point is them getting pancreatitis. Okay. And their guidelines are about if their triglycerides over 500, because we have known risk. The last page is looking at the National Lipid Association. Its chart at the top goes through their risk stratification. You should have a general idea about that. Do not memorize that chart. But what they do appreciate that what they do is they first look at is what is your non-HDL cholesterol. That first number in each of those columns is the non-HDL goal. Below that is the LDL goal. So that would be an important thing to keep in mind with them. Non-HDL cholesterol, if that's the guidelines you're gonna follow, is what they're first gonna target, and then the LDL goal. What they do in that last column is they tell you when should you consider drug therapy. So treatment goal, the goal means what am I gonna treat down to? The other one is when do I start a drug? That's always been the quandary. If you're slightly above goal, do we take the risk of putting you on a drug long-term to get down 10 points? The other thing is with cholesterol, what I told you the other day, LDL in total cholesterol, usually are going to vary around 10 to 15% of some norm for that person. So getting multiple, if you don't have somebody who's high risk, you want to do at least 2. In the lipid clinic I worked with at the VA with the endocrinologist, we always got 2. We never treated without 2. Unless they were secondary prevention, we knew we were going to treat them. If they were primary prevention, we always got 2, and we always made sure we ruled out any other problem that was elevating their cholesterol, which I don't see a lot of that done in primary care. Diabetes, and kidney disease, and thyroid disease are the big things to look at. Get them stabilized, the cholesterol usually will fall. Had a young man who came in, and he was the youngest of about 5 brothers, and they all had heart disease in their family. He did not. Now, he wasn't very old. He was probably early 30s. His LDL came in at 190. So we were like, wow, that's significant. So we did all our workup, and lo and behold, his TSH came back at 65. Okay, so normal is less than, what, 4? Okay. We treated this. His LDL came from 190 down to 125. We used to use dextrolevothyroxine to treat, before we had any of the other, we used those to treat high LDLs. So, he's just an example, he's one, but he's an example of treat the underlying causes before you decide on what their cholesterol is. Okay, under the very last page, National Lipid Association summary points. Their recommendation, this goes back to the old traditional recommendations, is once people hit 20, screen them every 5 years. Okay. Unless they get diabetes or heart disease, then you're going to screen them, or you're going to be assessing them more often. Risk stratification based on those risk factors. Remember what they are? What are some of the cardiovascular risk factors? Hypertension, diabetes, family history, right? Age, gender, smoking status. Know the LDL and non-HDL goals by risk stratification. So they're a 40-year-old man. They don't have diabetes, hypertension. What would be their risk? No family history. Don't have any, right? Male under the age of 45. Okay, so use low-intensity statins only if necessary. So that would be for tolerance. So there really isn't any recommendation to use a low-intensity statin unless they can't tolerate. Let's see. Non-statins are used to help achieve goals if you can't do it with a statin. They acknowledge that there's no evidence about using those combinations. Their primary target triglycerides is less than 500, just like the American Heart Association. Okay, questions? It's a lot of lipid stuff in 2 days. Okay, I will see you on Thursday for COAG.
Oh my God.